Mo, the doctor is in.
Yes, it is. Happy Woosah Wellness Wednesday. We made it another week.
We did. It's another Wednesday. It's another Wednesday. And
Mhm.
we have another great topic to talk about.
I
But Mo,
love this.
but Mo, did you know that, well, of course you did, but do most people know that nurses can be doctors?
Hope so. I hope they know it because it's so very true. I have a good friend of mine who is a physician. Her last name is Nurse, so she is Dr. Nurse. But
Really, I love it.
Absolutely. But yes, getting a doctorate in nursing is it's important for our community, for education, for practice, for so many things. And we're thrilled to have some amazing doctors with us today to talk about this very important topic because I do a lot of talks for primary care physicians and other groups, and everybody's a little bit confused about when and how and what types of screening women should get. And if the doctors are confused, then the patients are confused. And
Right.
so we're here to try to shed a little bit of light on it. I mean, it's about as clear as mud, but one thing is for sure, we can't afford to ignore the signs, the symptoms, and the screening that we need to get during COVID. So we're going to get into it. We're going to bust it up because the doctors are in.
Doctors are in. I know we got a posse today. But yeah,
Yes.
screening has, the numbers are pretty bad overall about screening and people, and they've gotten worse with COVID. But I found this article the other day that 47% of Black women don't know how often they should get screened for breast cancer. That's huge. That's like half of us. Half of us don't know when to get screened. And, so then I started Googling, of course. I went to Dr. Google and I put in, screening, breast cancer screening, breast cancer self-exam. And there's so many things. There's so many sources, NCCN. And, I don't know what these things are. American Cancer Society, there's all these sources. And how do poor little, I'm always like, talk to me like a 5-year-old. I couldn't find anything that really was clear. Now they're all kind of similar about age, and we'll talk about that, but we need some help. I mean, it's not crazy that people aren't getting it because it's so clear that nothing is there for them to even understand what they should be doing. And then we have the whole COVID thing happening and it just got worse. So
It's true. You know what the Bible says, our people perish for lack of knowledge. So we got to bring some knowledge today. So
yeah,
let's start with the knowledge bearers, shall
I
we?
know the doctor nurses, Dr.
All
Mary.
right.
Hi there. Welcome to this presentation. I'm very excited to join you guys and find out more about your organization and all the great work that you're doing. So my name is Mary Gillette, and I am a PhD RN, and I specialize in cancer care. I have been in practice for 43 years. Started when I was 5. So if you're trying to figure out my age. I am a past president of the National Oncology Nursing Society, which is based in Pittsburgh, Pennsylvania. And I practice at Emory Healthcare in Atlanta. And our Winship Cancer Institute is also part of that organization. And so I'm excited to have the opportunity to talk with you guys. So I'll pass the baton to my colleague, Dr. Felicia Williams, and let her introduce herself, and then we'll start bantering back and forth on some questions and answers.
Hi, everyone. Again, I am so happy to be here amongst you great, wonderful women and men. As Dr. Gillette said, we both are colleagues at Emory Healthcare, but I have to tell you a little bit about my background. So Mary was my boss when I came to Emory Healthcare. So I had a 5-year-old boss. And I started out as an oncology nurse, and Dr. Gillette has always been one of those people that kind of pulled stuff out of you, even when you weren't trying to let go. And so over the years, she's kind of mentored me as well. But I've always done oncology, nothing but oncology. And so I am a DNP. So I have a clinical doctorate degree as a nurse practitioner. And my specialty is medical oncology. And so currently I practice, I've worked with all solid tumor types, including breast, lung. Right now, my specialty is sarcomas. So I'm the lead APP in the sarcoma division, but I'm also the lead APP for all the physician assistants and nurse practitioners at Emory Healthcare at the Midtown and Grady campus in Atlanta.
What's an APP?
I'm sorry, an advanced practice provider. So, the term used to be mid-level, but it was like, that's not a good term because we're not mid between anybody. We help each other. So the correct terminology for a nurse practitioner or a physician assistant is an APP or advanced practice provider.
Great.
Absolutely.
Yeah.
Wow, you guys are awesome, like doing great things. So let's start talking about this craziness that we're in. Mo, you were going to say something?
I was going to ask Dr. Gillette to talk a bit about the research that she did so that we can open up this conversation about breast awareness and screening. So tell us a little bit more about your dissertation research, if you would.
Sure, I'd be happy to. I received my PhD from the University of Utah in Salt Lake City, and my practice and academic specialty was in clinical research, particularly around cancer. And so my program of research was about looking at breast cancer among African-American women. And I particularly had, because of some of my personal experiences in my church and in my community, I had questions about this spirituality and religious beliefs that were perhaps the cause of some women delaying seeking help or getting diagnosed with a change that they noticed in their breast. So we'll be talking about self-awareness. These women were aware that there was a change in their breast, but they did not seek help. And one of the things that we know is that early detection for whatever cancer saves lives. And particularly if you've got a breast change that you know that this is something different, it's not normal for me, whether it's bleeding from a nipple, whether it's redness or skin irritation that doesn't seem to go away, or whether it's a lump or a bump in your breast. And many of these, I researched, there were 120 women who were subjects in my study. And I actually did a mixed method study, which means you do the data part of it with the numbers, but you also get the stories from the women of why they are doing what they're doing or didn't seek help earlier. So what I found was that many of the women noted that there was a change in their breast, but they made an excuse about it. So they either chalked it up. One lady said, my boyfriend and I had a fight and I fell on this milk crate and I thought that was what was going on. Another lady said, I kept waking up and there was bleeding coming from my nipple and I just put a Band-Aid on it and kind of thought that was normal. And, it wasn't normal, of course, but the longer you delay when you have these changes because you're afraid or because you don't quite know what to do, the best thing to do is not just sit on it and hide it. The best thing to do is seek medical care, whether it's from a nurse practitioner, whether it's from a physician's office. Go in and seek that care to have someone evaluate it. At that point, it won't be a screening mammogram because you have detected a change, but it would be a diagnostic mammogram. And so that's the kind of thing that and women, I was seeing in my community, particularly in my church community, women, one of our mantras was, don't name it, don't claim it. So if you name it, you claim it. So it was like, oh, don't say the word breast cancer. And so when I would do education for women, I actually wouldn't even call it breast cancer. I called it breast health. So breast health. So, it's about the health of your breast so that they didn't get turned off or not even show up because they didn't want to name it and claim it so that it would be breast cancer.
Wow.
So those are some of the things that we run into and have challenges about. And I tell people all the time, I think, Mo, we were talking earlier, and you said my people will perish for the lack of knowledge. And what I always introduced my talks with patients saying, you will not perish for lack of knowledge. I won't allow it. And so I am going to make sure that you are knowledgeable about what's going on. And that's really what these sessions are all about that we're even talking about tonight.
I love that. I grew up, my grandmother had breast cancer, and I remember the first time she got it, she hit her breast on a cabinet, or my grandfather opened a cabinet door and somehow it bumped her in some kind of way. And she blamed that trauma on the breast cancer and said that
Mhm.
that cabinet, and she kind of blamed my grandfather a little bit too, to be honest with you, but she couldn't understand that, that probably alerted her to the fact that there was a lump
Yes.
in her breast. And we do have this stigma about not wanting to speak things into existence. And
Mhm.
I try to balance and toe the line with patients and with people when I do community talks, because some things we do have to name. Like I grew up, nobody talked about certain things. You called them a lot of different euphemisms, the tatas and the cookie and the this and the that. And there's something to be said for naming our parts and claiming ownership of them, but
Mhm.
also wanting to respect and balance, not speaking a thing into existence. Like we can speak health into existence, like you said, Doc, and I love taking that approach and spinning it on its head, so that it's not that we are speaking negative things into existence, but we can call it out and we can seek it out and we can shed some light on the subject. Don't you think, Dr. Felicia?
I agree. It's all about position of strength with anything. You want to come in knowing as much as you can about your body. As a young nursing student, as we sit in class and we hear about all these different, health disorders, and of course you're sitting there thinking you have everything in the world wrong with you, right? But as a young adult, I've always said I never want anybody else to know more about my body than me. And that even comes down to doing the self-breast examinations. When I was doing actually my research project as a DNP, I actually wanted to focus on something that was a little different with breast health, because it's all about knowledge. And so sometimes we have lapses in healthcare, meaning we don't address all those things that women want to know when they come to us, right? And so I did my project on sexual dysfunction with women with breast cancer. And so it was different, but I found through that women were really not in tune with their bodies a lot of times, because of those value systems that we kind of grew up with. We weren't comfortable. Our parents weren't comfortable talking to us about certain things, right? And we just kind of adopted those kind of euphemisms over the years, and we taught our kids that. And so the more we know about ourselves, the more empowered we can be. We run companies, we run the world, but for some reason, we kind of just let our own bodies go and we take care of everybody else.
It always amazes me too how, and maybe because, I have fake breasts and I look at them all the time. But so many of us don't even look at our bodies naked.
Mhm.
You know what I mean? We get in the shower, we get out the shower, we put our clothes on, and maybe I'm a crazy person. I look in the mirror every day to see if something's different. But
It's a good practice.
I know, but we don't do that. We don't look at our bodies. We don't touch our bodies, and and we don't know what even normal feels like, right? Because we're not doing it. Having a conversation with our bodies, and you have to know you're normal to even know that something's wrong. And if you have this stigma from your mother, like, or from your family.
Yeah, I think it starts from youth though, and I think that if we as loved ones, as parents, don't feel equipped, because we never learned what normal felt like, right? Like we didn't talk about it. My grandmother, there's certain things that we didn't talk about. We didn't talk about health, and we didn't talk about money, because there was two things we didn't really have a good grasp on in our families. And so it's up to us to talk to our doctors and seek out what normal feels like. And like I tell people all the time, especially when I go to advocacy meetings and supports and give talks to these sororities and things in churches, talk to your doctors. And it's a dialogue with them about, well, what does this feel like? How should things feel? And they should be educating you, and you should be asking questions. Like there should be a whole exchange in that exam room versus the doctor says this, and types and never looks at you and then puts his hand on the doorknob and walks out the room. Yeah. You got nothing out of that. And so if we don't know, starting from pediatrician, starting from, GYN's office, start having that conversation. And that brings us to the point of, at what age should somebody start thinking about what their risk is for breast cancer? And I'd love to get everybody's opinion. Ricky, you as an advocate and as a patient, and then our docs, when should we start putting this on our radar?
Well, you know how I feel, Mo. I think we should learn about it in high school. I think when you're going through puberty, you should start thinking about, But definitely when you go to your first gynae appointment, or when you're saying, I want birth control, and you're, thinking about sex or whatever, however old you are, you should be thinking about breast health. You should know about it. And what we're learning from our HBCU internship program, most of our interns are, 19, 20, and they've never talked about it with their moms. They're all have gone to a gynae appointment, but they don't talk about it. And so the conversations that we expect them or have them have with their moms, or they do a video with their moms, they've never done it before. It's for the first time at 19, 20.
Yep. Somebody just put in the chat, my family never had these conversations.
No.
So what do we say to the person whose family never had these conversations? But we'll get to that in a second. But I want to know, when should we start thinking about it, putting it on our radar, docs?
Well, I think it depends on a couple of things. One is, what's your family history that you are aware of? And that kind of leads to having an assessment of your breast health. And, the guidelines report over, as soon as you start getting over the age of 25, you should have that assessment of your breast, and it goes into the history. Do you have any sisters or aunts or cousins who are female who have had breast cancer that you are aware of? And that kind of sets the tone for when you should personally start getting your first mammogram and those kinds of things. But the guidelines say that the mammogram should start at the age of 40. But if you've had a family history, it needs to start earlier than that. And again, one of the things that I hear many times from women, particularly younger women who come in with a diagnosis of breast cancer, is that, I had this problem a couple of years ago or last year, and my doctor said, don't worry about it because you're too young to have breast cancer. Don't ever let anybody tell you that, and that you take it for granted. And I know you're afraid, and I know you're thinking, I just want to hear somebody say it's okay. And so now I won't worry about it. But yeah, you still need to worry about it. If there's a change in your breast for whatever reason, whatever age you are, young, then you need to get a follow-up with a mammogram. Dr. Felicia, what are you thinking?
So, I just wanted to add to, even though when there's a change in your breast, you have to know what a normal breast is supposed to look like. And so if a lot of times, if that's not coming from our parents, who is it coming from? So, I would say, as we get older in our early 20s, I think it's important, vital for us to just kind of start looking at our breast in the mirrors, because you don't always need to run to the doctor, right? So you need to know your breast. You need to be familiar with what they look like in the shower, outside of the shower, during your menstrual cycle, outside of your menstrual cycle. What do they feel like? And so then when you do notice that a change occurs, then you feel more comfortable with following up. But I just wanted to add that a lot of times we tend not to follow up because we're fearful, right? We're scared it's gonna be that big breast cancer word, but we're not told it could be so many other things that's benign, but it's just about empowering yourself. So early 20s, just getting to know your breast, feeling them. I never will forget early years. I went to Tuskegee University undergrad, and I remember sitting in one of my history classes, and this guy sitting next to me, I don't know how we got on breast health that day, but this guy, he just kind of stood up in the room and he said, look, guys, all of you like to feel on women's breasts in the room. He was like, but he was like, you need to know what they feel like and what's different about them too. And I thought about it. I'm like, wow, because in my clinic, it's not always the women that find something wrong. It's the husband or the significant other. Yes. So those early years.
Yeah, we have a breasty friend. Her name is Shantae, and she's precious, but she's actually a nurse. And she started having breast issues at age 25. Different lumps, whatever. And she works for the military. And so she went into her doctor for 5 years and got dismissed as a nurse. saying something is not right here. I don't feel right. And oh, you're not, it's fine. You're nothing, whatever.
Yeah.
But finally at 31, she finally was able to convince a doctor to give her her first mammogram, and she's de novo. She's metastatic. I mean, well, who knows if she was metastatic when she first started going, but she was diagnosed metastatic. She's now 36, fighting like a girl, but she had bone met. She had one of her hips was almost totally deteriorated. She had all kinds of issues, but was from being dismissed. And she was advocating for herself. So think about the women that don't. How many are out there that don't know to even advocate? And then the whole fear, you brought up a whole other, the fear thing, Dr. Felicia, is just, wouldn't you rather know than not know?
No, people
No.
would not. Let me tell you, from this
Yeah.
side of the table, I see so many people, and it's not an educational level kind of thing.
No,
It's not a race. It's not a religious thing.
Mhm.
It is a fear thing. One, they've seen their family members go through it and they saw a very horrible experience. Two, they see a lot of things on TV. Three, they don't know. And it's that fear of the unknown. And that's why I always ask, when I talk to survivors and thrivers, I say, okay, so when's that pivot moment? And what did that look like for you? When did you go from being paralyzed with fear to being like, you know what, I got one life to live and let me get to it and let me, turn this into whatever, activism, faith, whatever it is that moves and motivates you to get up in the morning and do what you do as far as helping others in their breast cancer journey and knowing their risk. But the fear is paralyzing and it's overwhelming. And, there's somebody chimed into the chat just now. My family doesn't talk about these things. So where do I go? How do I begin to assess my risk? And I think, Dr. Felicia, like you said, taking it from a strength-based standpoint. Okay, so if you can't get anything out of your family, which one, I think we can. When we talk to our loved ones about their life story and their stories of strength and overcoming, we like to talk about being strong Black women.
Absolutely.
And a lot of times our health history comes out when you frame it from that perspective. But if you can't get anything out of your family about your history, all the more reason to tune in to
your own
yourself.
body. Yeah,
Mhm.
absolutely.
So what does that look like? How does somebody tune into their own body? Give me some tips.
Well, the first thing is like I think we've all said, is you've got to know your body, and you got to touch your body, and it's okay. You're not going to perish.
Say that again. Say it
You're
again.
not going to perish by touching your breasts. You're not going to go to hell all of a sudden, and God's going to smite you down because you touch your breasts. But take a look in the mirror. You take a shower, you take a bath. It's easy to touch and rub your breasts when they're wet and soapy, and your hand glides better. You can feel things differently. And in the past, we've talked about the three aspects of a good breast health check, and that is breast self-exam, clinical breast exam, and a mammogram, and a screening mammogram, which means I don't have any changes. I just need to make sure that I get a baseline. And so of late, many of the recommendations are steering a little bit away from the self-breast exam because it was so burdensome to so many women. Number one, they weren't doing it. Number two, many weren't doing it correctly. Number three, who could remember? Do I do it on the 25th of the month? Do I do it on the 5th of the month? Do I, when do I do it? So you just didn't do it. And so because of that, people were relying, we as scientists were relying on people to detect something in their breasts and then seek medical care. But if they're not touching their breasts, they're not going to see, or looking at their breasts, they're not going to detect anything. And I think, like Dr. Felicia said, it's every change does not mean it's cancer. So let's be bold about it, and let's go make sure it's not cancer, as opposed to thinking that it is and there's nothing I can do about it. And another thing with my dissertation on looking at religious and spiritual beliefs on delays in seeking breast care, that women were, let me just pray about it. Or they would go to somebody in the church and they would say, well, let's just pray about it before we do anything. And, I have this story about prayer without works and you're dead. And so you need to do something about it. I have this little quick story about somebody caught in a flood, and as much flooding as we've had lately is certainly realistic. And the people came by in the car, the police came by in the car and said, hey, the flood is coming. You need to get out of here. No, 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 I'll be okay. I'll be fine. Just go on. I'll be fine. I'm not going to leave my house. And then the water just kept rising and kept rising to the point of the cars couldn't come through. So now a boat comes through and the person goes, come on, you need to go because it really is going to continue to rise. No, I'll be okay. I've got 2 stories in my house. I'll just keep climbing and going up to the next story. And so the next thing that happened is you see this image of this man on top of the roof, right, of his house, because the water level has gotten that high in a 2-story house. Now he's on top of the roof. And now helicopters come through, right? And sir, let us take you, let us rescue you. No, I'll be just fine. I'll be just fine. Don't worry about it. The water's going to start going back down. I'm covered. I'm good. The next scene is that this man is at the pearly gates. Okay, so he has perished and he's at the pearly gates and he asked God, oh my gosh, you said you were going to save me. What happened? And God said, I sent a man in a boat. I sent a man in a car. I sent a woman in a helicopter and you didn't get in. Okay, so it's on you. You know, God gives us people with knowledge
Yes.
so that we can support and help each
Yes.
other. And that's what we're here for. So just remember that story when you're thinking about, I'm not going to go and seek care because, and I'm going to pray about it instead. Well, you know, pray on your way to the doctor, to the nurse to get your exam. Pray on your way there.
Right. Pray that
believe
the
in prayer.
doctors, pray that
I
the
was just
doctor
gonna
can
say,
do
pray
right.
with us.
Yes,
Pray with the
right.
doctor, right. Pray with the doctor. Pray that the hands that are going to touch you are going to help you, you know.
absolutely.
And I mean, you know, I am a faith walk, you know.
Yes.
My doctor gave me 2 years to live, and on September 21st, I'll be 10 years, you know, 10 years from my diagnosis. And so, I mean, I had to relinquish my faith.
Mhm.
So it's not even about faith. You have to use your faith. You have to
Yes.
use your faith, and that's what's going to get you through this
Yes.
craziness. But
Yes.
you can't not do anything. Faith
Mhm.
without works is dead. If you can't, and so the fear, you have to turn your faith into fear. I mean, turn your fear into faith,
Mhm.
and to take this walk. But I don't know. We have a lot of work to do, and I think, you know, if we can kind of try to minimize the confusion for people, you know, and like say, okay, here are the rules of engagement for screening, you know, and what you should be doing, like know your body. So the first one is know your body.
Mhm.
Take a shower, feel your boobs. It's okay. You know,
Look in the mirror at them. You don't even have to touch
Yeah.
them. You can just stand in the mirror and bend forward.
right.
Let
Yeah.
your breast hang.
Yes.
See if there's an imbalance. See if there's
Right.
a dimpling in one breast versus the other. What changes are you noticing?
Yep.
Yeah.
I teach patients when I see them in my office and they come for a risk assessment or breast pain or something else. And I say, okay, so has anybody ever taught you how to do an exam or how to practice self-breast awareness? And they say no. So then I'll pull the mirror down and I say, okay, we're going to look at the girls in the mirror. You know, we put their hands on our hips and we're going to look, we'll put our shoulders back so we can
Yes.
see our chest wall, put our arms in the air so we can
Mhm.
see underneath if there's any
Mhm.
dimpling or anything underneath.
Right.
And I make it fun. I say, okay, put your hands in the air, wave them like you just okay. And then they do it. And then we laugh because I'm kidding, you know, and we talk about the nipples and how they're twins, right? One is always kind of doing a little something different. They're never exactly identical,
Right.
right? One's always
Right.
a little larger, one breastfed better than the other. One is, you know, and that difference is okay. And then we feel them standing up and then we feel them laying down.
Down.
And we go
Mhm.
through all three so that you can understand that when you feel something this way, if you lay down, it'll feel different. It may feel different, but how a
Right.
cancer might not feel different, right? Normal change is change. When you standing up and then when you lay down, everything goes this way, right? And
Mhm.
it feels a little bit different. And so knowing how it feels when you're standing up and when you're laying down, and these are the things that I think that we really do have to, you know, work on teaching people to do
Yeah,
for
it's okay.
themselves.
It's
Yeah, and that
okay.
it is
It's okay.
okay.
It's
You know?
okay. In fact, it's necessary. It's necessary.
Dr. Felicia, when women ask you about breast density, what do you tell them
Definitely.
and how do you educate them about the density? You're on mute.
You're on mute, babe.
Yeah, I'm sorry. Yeah, so the dense breast is a big phenomenon. Well, not a phenomenon, but it occurs a lot. A lot of us have dense breast. And so those of us that do, first of all, you have to know if you're truly dense or not, because a lot of times we use that as a go-to term when we really don't know. So you shouldn't be saying your breasts are dense. A provider or clinician should be saying your breasts are dense after the appropriate imaging has been done. It's not just a term that compromises everything. Like to say diagnose dense breasts, honestly, you have to rule out everything else, right? Because you want to be on the safe side. And so dense breast doesn't even really just come after your first mammogram. It takes a while to know that these are truly dense breasts and follow up. A lot of women will go for the mammogram and they've been told dense breasts or whatever, and they never go back, and because they assume they're fine, because that's just how their breasts are. But it needs follow-up because dense breasts can still turn into breast cancer.
Yep. And if you don't know if your breasts are dense or not, you need to go get checked and have the doctor, and it's through imaging, right? Through mammograms, and the doctor can tell you. I think also we learn that, when you go to get a mammogram, get a 3D mammogram.
Mm-hmm.
And that will give them much better,
clear pictures. Yeah.
Clear pictures of what you are. But if you don't know what dense breasts are, you need to go get checked out now.
Yeah.
And ask your doctor, because when you get your letter in the mail after you get your mammogram, the bottom of that letter usually says something like the sensitivity of mammography is significantly diminished for heterogeneously dense or greater breasts, right? There's a statement. And they're like, okay, so does that mean I have dense breasts? Does that mean my mammogram wasn't a good one? What does that mean for me? But the density, like Dr. Felicia said, is determined by the mammography, the amount of glandular, for radiologists, the amount of white stuff on the screen. And I tell patients it's like static on a console TV. And I know I'm dating myself because people don't know what console TVs are. And I got to find something for the 20-year-olds because they just look at me like this. Like, what is a console TV? But it's like static on the TV screen, right?
Right.
The more static you got, the harder it is to see the picture. And so, doctors always go, yeah, how you have dense breasts, see you later. It's not the feel. It's the amount of glandular stuff in the breast that makes the milk, that makes the cells, that does stuff, the white stuff. And so it's determined by your imaging. There's categories of that. And everybody falls into a category, whether it's A, B, C, or D, or 1, 2, 3, or 4. The amount of density is something that you're going to get. You're going to get a letter in the mail, and you got to ask your doctor, what do I do with this? I'm 25% dense. Am I supposed to do something more? Because they don't tell you what to do about it. They just say, here's your density.
Right.
And many times they will say that you need to come and have,
have a sonogram.
Yeah. So
that's what they should do. I know our center did not for a long time. And I said, you guys are sending a letter out, not telling women what to do. You're saying your breasts are greater than 75% dense, but you're not telling them what they should do about that. And so we started to put that in, but there's still no good, hard consensus statement or guideline about whole breast ultrasound as part of the actual screening requirements. It's all sort of optional, can consider, and it's a little bit nebulous, but when you get that letter and it tells you your density, you got to use that information and act on it, because maybe you should be getting ultrasounds in addition.
Absolutely. And I know many women sometimes, last year I went and they said it was this, and I had an ultrasound and it's okay. And so next year I need to go back. And so why can't I just go straight to an ultrasound instead of getting a mammogram? And, I know it's painful, it's uncomfortable. You're twisting and turning all which ways to try to get all the imaging in there so that we can make sure that we're looking at everything we need to with the connective tissue and the glandular tissue and the fat tissue that's in the breast. But, I always tell people that if it hurts, it's uncomfortable, and it must have been a man who invented that, because if it was a manogram that needed to happen,
it'd be different, right?
It wouldn't be as hard and hurtful. So, but and all kidding aside, we really need to make sure that you're listening to what's going on. You're keeping a record of the documents that you get back from your provider after you've had your mammogram, the digital mammogram, the 3D mammogram. All of those are more diagnostic, and for the most part, they're not even doing the old-fashioned regular mammograms anymore.
Right.
So you get that automatically. You don't necessarily have to ask for that when it's a screening or even when it's diagnostic.
But a lot of women haven't had their first mammogram and are over 40. I met a woman last week, Martha's Vineyard, Mo, 46. She had seen our show and heard me talk about it. And she came up to me on the street and said, I'm 46. I've never had a mammogram. Should I get one? I'm like, oh my gosh, let's go. Where's the nearest hospital? I'll take you. But
Wow.
but,
Does she have a reason that she
she
hadn't
just
had
said, I've been afraid to do it. I'm
Uh-huh.
busy. I didn't really think about it. My mom didn't have breast cancer, so I'm okay.
one? Mhm. And I heard that it hurts, so I don't
It
want to go.
hurts, yeah, I don't want to try it, whatever. So, I mean, we have a lot of work to do to educate, and why 40. And then, the other statistic that scares me is that Black women under 35 get breast cancer at twice the rate and die at 3 times the rate. So getting a mammogram at 40 doesn't work for us.
Mhm.
So I think when you start to think about, okay, well, what should we do? What do we need to do as Black women? Our breast cancer is not the same, and we're getting it younger, we're getting it metastatic, we're getting it at later stages. And so, that's why it's so important to be educated young, but also what do we do? So what do we tell people? What should they do?
Well, docs, I think that's a great question for us. What do you think about the guidelines changing and about, different societies recommending more
Right.
aggressive screening for Black women? Do you think that that's going to become the norm in time, or do you think time will tell?
Right.
Well, I think a little bit of both. It's really about what do? You know your breast. We can't say that enough. Know what normal is for you, and regardless of that age. And then you get clinical breast exams before you even have to get a mammogram. You can go see your provider, and the screening with the Affordable Care Act. Those screenings are they're free. For screenings, not for diagnostic. So
Right.
it's important to go and get that screening done, even if it's just by your provider doing a clinical breast exam. And they call it clinical breast exam because someone else does it. It's either the nurse practitioner or it's the physician who is doing that breast exam for you instead of you doing it for yourself. And that's important. I can't stress
Right.
that enough. Felicia?
Right.
Yeah, so I think with the new guidelines, I think it's just going to be pretty much more pinpointing with the minority community in certain types of cancer. Same thing with GI. If we think back 20 years ago, even with other disease types, screening numbers have gotten lower over the years, younger in age. I'm just thinking about colonoscopies. At first it was wait until you're 50, then so I think over time that's going to be our normal world, that these guidelines are just going to start getting lower, and not necessarily a bad thing, because I think we were missing a lot of people because the guidelines weren't really relative to the incidence and the actual population. And so I think a good part in that is that I think the rest of the world is now starting to pay more attention to us and our needs, things like that. We're not quite there yet, but I also think it's up to us to be in the forefront of that. And so just kind of going back to screenings, I found in the clinical setting, if I can get a woman to go for that first mammogram, she'll be much more likely to continue to go because she's heard all the horror stories. Once she goes for herself, yeah, it's uncomfortable, but it's doable, right?
Mm-hmm.
And then I admit, even with me, I feel a sense of empowerment after I walk out, like I've done my duty for the day,
Right.
And so I'm ready for the next one. I'm not as fearful, So we're natural born leaders, and I think it's up to us to heal us and get us right. And so we have to reach out to family and friends and, hey, go with me. When we don't want to exercise, if we have somebody going with us, we'll go,
It's true.
making us accountable, right?
Wow.
Yeah, I think
I love that you said that, because it is like voting, isn't it? It's like after you leave that voting, but you feel like you did something. But
Yeah.
you know what my secret sauce is? And I tell patients 2 extra strength Tylenol an hour before the mammogram. It's not going to make all the pain go away, but it does make it just a little bit more comfortable. It takes away some of the pinchiness. I know it can pinch a little bit. I know. I know, but when you look at the alternative to it, mammograms detect cancers, many cancers, up to 3 to 5 years faster
Mhm.
than even our hands do.
Yes.
And we're not saying it's the only modality, but we get a lot of questions in our chats about, well, they always call me back for an ultrasound. So why can't I just get the ultrasound instead of the mammogram? And well, what about thermograms? So I'm going to invite you guys to weigh in on the different types of exams and maybe help to reinforce, when and why women should get a mammogram over other types of imaging.
And frankly, you guys, getting a mammogram doesn't feel as bad as cancer. So, you know,
That
Good
part.
point. Good point,
cancer
Rita.
hurts a lot
Yeah.
more than bad. Okay, I wish I could have gotten a mammogram and had not had cancer.
Mhm,
Trust me.
mhm.
Mhm.
Absolutely.
Mhm. So what kinds of, and maybe we should just tell people what to do. Like, what are the different things? What are the options? And what do you do? What do you do? When do you do it? What do you do?
Well, there's different scenarios, right? So if you're too young for a mammogram and you feel something, you go to see your doctor, right? And you do not leave without a plan. Someone should feel what you feel. Someone should either perform imaging in that office or then order imaging, and someone should be giving you a follow-up plan thereafter so that you don't just leave thinking, okay, well, I guess that's it. No, it's, well, what to look for? When are we going to check it again? And that way you have the next step. So if you're too young for mammography, or I guess I'll just say age. If you're too young for mammography, ultrasound would be an acceptable way. If you've got high risk, then we're looking at MRIs as well, starting at around age 30, wouldn't you say, docs?
Mhm.
Mhm.
Absolutely.
So
Well, the
that's
guidelines.
why you got to
I
know your
do-
risk.
Or 25,
Mhm,
Right.
25 to 30. Yeah,
25
you're
to
right.
30. Mhm.
Yeah.
Well, the guidelines say you should get a risk assessment, right?
Mhm,
Right.
Yep.
A risk assessment sometime before 30, right?
Mhm,
And
25 at least. Yeah.
so what does that mean? What's a risk assessment and how do I get it?
Well, again, that's part of the profile when you go in to see your provider. So whether that includes a history, it includes your history, it includes your family's history, it includes your, obesity, all other kinds of risk factors that go into breast cancer developing or any other type of cancer developing. And, as Felicia mentioned earlier, and historically, the data and these guidelines were produced based on a majority population because we weren't involved
Not
in
black
clinical
women,
trials.
right? Not black women.
We were not involved in clinical
It's
trials.
true. Gale model was not
we-
built on us. Yeah, it
Yeah,
wasn't
it was
validated in
not.
Black
It
women.
was
Yep.
not. So finally, after seeing the mortality or the death rate from late stage cancers, which is why there's a higher death rate among African American women,
Right.
is the stage of disease at the time of diagnosis. That's one of the things that's changing and transforming. That is a positive thing, and that's what's causing those guideline age limits to be lowered from what it has been in the past.
So I should go get my risk assessment. Do I go to you're my general practitioner? Who do I go to for that risk assessment? I'm 25. I don't have a history that I know of. Do I go to just my regular doctor? Do I talk to my gynae about it? Like, who do I go to?
I think it starts with a PCP,
Your
a
primary care
primary
provider.
physician. A primary physician, because if you're not symptomatic, you should be going for just your yearly follow-ups anyway.
Right.
And
right.
so that's usually going to be your first line of defense against anything, is a good primary care provider that's asking you about those things. When we go into offices now, everything is electronic and we check all those boxes. If we have a family history of this or that, that's part of developing your risk assessment. So there's a reason for checking boxes, yes or no, because that gives the clinician an idea of what they need to lead into a little bit deeper as far as your clinical visits. For example, do you have a family history of breast cancer? Did your mom or grandmother have breast cancer or ovarian cancer? So it guides us on what we kind of need to just kind of, beam the headlights on when we do see you.
Mhm.
I honestly have never had a primary care physician do a formal risk assessment with me. They'll ask my family history, they'll put it all on the computer, but I've never had anyone sit down and do either from a PCP office with my family history. My mother died of ovarian cancer 29, and my grandmother had breast cancer twice. Nobody ever sat down and did either Gale or Tyrer-Cuzick model. And those are different types of online risk calculators that people can do. So when I talk to patients and do like workshops and things, especially during Breast Cancer Awareness Month, I put those in the chat because I think you should ask your doctor for a formal risk assessment using some type of a calculator, and understand that they're not the end all be all, right? And many of them were not validated on us. But the Tyrer-Cuzick takes into account your age, your weight. Did you have a biopsy? Your age at your first period? What type of biopsy did you have? Your cousins, right? Your aunts, your uncles, and it gets a lot more family history. And so I put into the Facebook chat a link for an online Tyrer-Cuzick risk calculator that you could do at home even. And you can take this information, and if you do it, it'll force you to start asking some questions and get some more family history. And then you can take it to your doc, because you might not do it right, and that's okay. But you can start collecting as much history, talk to the cousins, first cousin, second cousin. We want to know it all. Bring all that family history. And some provider should sit down with you and actually go through that history with you and say, okay, based on this history, you are average risk, you are moderate risk, you are high risk, and here's what your screening should look like. So when people don't feel like they get that, I encourage them to come see a breast surgeon, because it's what I do. In addition to doing breast surgery, we go over your family history, we do genetic testing, we go over breast pain and fibrocystic breasts and all those things. And so you can refer or ask your doctor to send you to a breast specialist, and they can help with that too. If you think, you know what, I'm not really sure where I fall and I don't feel like I'm getting everything that I need, get a referral to a breast specialist.
Yeah. I think also you got to talk to your mom, talk to your aunties, talk to your grandma. You know, my mom, so
It's
my
hard
mom,
though, Ricky. Cancer is
I know.
traumatic in family. This is a horrible, it
Yeah.
robs you of everything. Like, how do you get to that point? If your cancer took your breasts, it took your confidence, took your sexuality, your intimacy, took your retirement savings, it took, it takes so much. How do you get people to open up about that?
I know, because my mom had stage 0 breast cancer, probably like 15 years before me. And she had a lumpectomy and did radiation really by choice because she was stage 0. But she's really why I kept getting mammograms, because she would sort of force it. But it wasn't until I got sick that she remembered that her aunt died at age 42 of breast cancer. I'm like, well, mommy, what made you think about it now? But it wasn't until I got sick years later. She never thought about it when she was sick. And then she said, oh yeah, because I was talking about triple negative, and I'm wondering, like, where did it come from? And she probably had triple negative at age 42 back in the whatever, when she died in the 50s. But we don't talk about this stuff. It's not conversation for Black people, and we need to put this stuff on the table.
Yeah, it's got to start with that conversation with yourself first.
Yeah.
And I tell you another quick story. My daughter, I do talks all over the country, and used to a lot more than I do now. And when my daughter was 13, she's 32 and married and has a baby and all of that stuff now. But she was 13 and I took her with me. And so she was sitting out in the audience, and I was going over the breast cancer information and the screening and the symptoms of breast cancer and all of those kinds of things. And every time I look out at her, she had her head down, so I didn't think she was really paying attention, right? But she was listening. And, she was 13, so starting this puberty thing. And so about a month later, she came to me and said, Mommy, I need you to check my breast because I think I might have breast cancer. And I said, oh, really? So why would you think that? She said, well, I was listening to your talk, and, it was during her menstrual cycle, and it was during the time that her breasts are starting to develop. And so they were changing, and there were little lumps in there. And so, but it was that awareness that she had.
Yeah.
That said, she could have sat on that and just got totally depressed about it, that I'm 13 and I'm going to die from breast cancer. But she was bold enough to come to me and ask the question, and put her totally at ease. And so we went over this whole thing about the breast development, and the same thing for those of you who may be listening, who are still having your cycle. You're going to have different breast changes during the time of your cycle. So when you're feeling that and the tenderness and all of that, and you're thinking, oh my God, is this breast cancer? No, you need to wait until after your cycle, 7 days or so after your cycle, and then check again to see if you still have those changes that you're feeling. And I think it's really important to talk about the difference in screening mammogram and diagnostic mammograms or tests, because screening, meaning you don't have symptoms of anything. So there's no breast changes that you've noted. It's just routine. Diagnostic is now that you've gone to your provider or that you felt something, that's when you need to change that paradigm and say, oh, okay, I really need to get a mammogram. I don't care if I'm 25. I need to get my mammogram now because there's something going on here with my breast. So that's my recommendation.
Yeah, so the diagnostic is when you have something happening or you feel something or something's out of order.
Something's different.
But I
Absolutely.
mean, the bottom line is go to the doctor, get checked regularly, get your annual mammogram. And
it's important though, especially during COVID, because I'm seeing a lot of patients who said, well, they told me not to come because, of COVID, right? So we had this whole period a year ago where we told people not to come in, not to get their screening, right? And people didn't understand the difference between screening and diagnostic. So people who had a breast issue waited. And now I'm seeing patients with inverted nipples, with bloody nipple discharge, with lumps that are bigger, with skin changes, all the things, all the signs and symptoms, because they said, no, we waited because we weren't supposed to go to the hospitals. We weren't supposed to come in. Screening is different than diagnostic. And Doc, you really, you hit that strikes home, because who knows if COVID is going to come cycling back around, because we already see it. We see what's happening.
It's not over.
It's not over. It's still going on. But if things shut down again, right? You got to at least know your own body. And you got to know that if you feel something, you do not wait. Diagnostics does not wait.
No.
I love that you brought that up. Dr. Felicia, when does a person stop getting mammograms? Because some I go do talks at some of the 55 and plus communities, and they're like, all right, well, I'm done, right? I'm good. When can I stop?
Some people never stop. I have 90-year-olds that still want to get their mammography. And, but first let me say 90 is the new 80, because I have some 90-year-olds that are great quality of life. Yeah. And if they are, go get your mammogram. It does not have to end. It comes a point though where you have to kind of weigh the risks versus benefits, right? So let's say if you do have a spot there, are you going to possibly get radiation or be able to do surgery or chemotherapy? So all those things have to be taken into account. Some women at that age or men at that age, they know, look, God has, and they've told me this before, God has given me a good life. If something is there, I'm just gonna have to watch it. I'm not getting any more surgeries. This body is not going through anything else. And so if they have that mindset, then I'm fine. You don't have to get it. But I always encourage women, like, don't stop. If you want to continue, and if you want to possibly be treated and you're already having a great quality of life. Yeah.
I love that, because if you're 90 and still wearing lipstick and still driving, guess what? You should probably still be getting your mammogram. And when we find things early, we're starting to do even vacuum assisted, right? Like we can just suck out certain masses. We don't even have to go to surgery all the time. They call them vacuum assisted and percutaneous biopsies and things where the little basket comes in, and we can take out whole cancers almost. That's going to be in the next 5 years, we're going to be able to do a lot more without going through a formal surgery and all the things. But if we don't look, if it gets to the point where it's too big, then you have to go through things like surgery.
We have a comment. We have a comment in the chat. I don't have mammogram because when I went to get it, I was told my breasts were too dense to get a mammogram. What?
I've had people tell me that. And they say, you can't see anything. And I've looked at some mammograms that look like a snow cone. Like you can't see a thing. Everything is white, but that doesn't mean you shouldn't get a mammogram because the calcifications, those little tiny granules, they show up and we can invert the pictures, right? So the white can be black and the black can be white. The
Mhm.
3D mammograms have 9 slices through forwards and backwards. You didn't know your breast was in a movie, but your breast is in a movie and we play the movie forwards and backwards and forwards. We can see layer by layer through that breast. And so for dense breast, 3D mammography is one of the most sensitive tools that we have. You got to get that 3D mammogram forwards and backwards. And yes, you may benefit from something like whole breast ultrasound in addition to,
Mhm.
but not in place of.
Place of, right.
Now, Doc, what about MRIs? Because, you know, people been asking, they're like, well, just skip all that and just give me the MRI.
The MRIs have, you know, there's a risk of radiation for having all the MRIs. So you need to also be careful about not thinking that you can just go get an MRI and that'll take care of it. It's also very costly. And if you don't have insurance, or if you have a big copay or whatever, then it's going to be a financial burden. And now you're not going to go do it because it's a financial burden. So you've got to really weigh in on all different options in terms of the diagnostic, because the MRI is for a diagnostic, that's not for a screening. And so you really need to think about what that is that you're asking for before you go in to ask for it.
Yeah, I've actually had a couple conversations where a woman went to get her annual mammo and it was free for Obamacare, whatever, that there was no
Mhm.
cost,
Mhm.
but it came back funky and said, come back tomorrow to get an MRI or a diagnostic, test. And she's like, well, I don't have insurance. I can't do it. And they don't go. And then 2 months later, they're metastatic or whatever, you know what I mean? So, the whole insurance thing, that's a whole nother animal. We can't even get there,
Yeah, it is.
It is.
Yeah,
A
it
lot of cancer programs have a financial person who can start to help with some of that stuff, because
Yes.
I've been the ordering doctor on those mobile vans, and we should talk about that, because guess where those mobile vans go? They go to our communities, they go to
Right,
our churches, and the
right.
mobile vans are not 3D. Many of them are not. They're still 2D. I
Mhm.
had a patient come see me. She'd gotten her mammogram faithfully every year at her job because a mobile van from a local cancer center went out there. And then she came to see me one year. She got her 3D mammogram. She said, but I got my mammograms every year. And the 3D mammogram picked it up and it was already stage 2.
Mhm.
And so we got to make sure that we are giving our people the highest level of technology. So when you go to those mobile vans, you can ask and we can work towards, and, we're going to have to probably do some grant writing and some other things to make sure that those vans have the technology that we need. And yes, some mammogram is better than no mammogram, right? But that 3D technology for Black women and for dense breasts is really is superior. I can't tell you that the difference that you see is like the difference between console TVs and floor models that my grandmother had and the flat screens.
Mhm.
The picture quality is just that much better.
Right. All right, guys. So let's break it down, right? Talking like I'm a fiver. That's why we said Dr. Felicia and Dr. Mary. So get your risk assessment somewhere between age 25 and 30, right?
Mhm.
Then know her story. Talk to your mama, your grandmama, everybody, your aunties on both sides of the family, right?
Mhm.
Everybody got to talk to everybody. Then the guidelines say get your first mammogram at 40.
Well, know your body even before.
Know your body. All right, so before that, know your body. Look in the mirror. Feel those girls. Touch them in the shower. Whatever you got to do. Right. I feel mine all the time. And anybody can feel mine. I don't really care. Right. So, I made everybody feel my tumor. Everybody. Everybody I knew, because I wanted them to know what it felt like. So know your body. Get your mammo at 40. Get it every year. Know your body so you can check your breast, so you just know what feels right or doesn't feel right.
Mhm.
If you have anything that feels weird or looks weird, a discharge, whatever, go to the doctor. Do
Mhm.
not pass go. Do not collect $200.
Right.
Go to the doctor and get checked.
Yes.
Don't wait because of COVID. Don't
Don't
wait.
wait for
Don't
any reason. Don't wait. Pray on the way there,
Yes.
right? Pray when you're in the waiting room, but go. And I think even if you take somebody with you to get your mammogram, take your sister, take your girls and then go to lunch,
That's what
right?
I say. Make it
Get a breast
social.
buddy. Get a breast
Get a
buddy.
breast buddy, yeah, your breast friend, take them with you, but make it a party,
I love it. Your breastfed.
You
Yeah.
take your breast friend,
Breast buddy.
right? So y'all go do your breast your best friend date. So go get your mammos and go to lunch, go shopping, go hang out, buy some shoes, whatever you got to do. But make it a family affair. Take your mama, take your auntie, take your grandma, and and take your daughter.
Take your daughter and take 2 Tylenol if you can, if your liver's okay. I'm just throwing it out there. Dr. Mo's little 2 cents about an hour beforehand. If you're worried about the pain and the pain, just take 2 extra strength Tylenol. Don't take any ibuprofen or Motrin, anything that makes you bleed, but just take 2 Tylenol. That way, even if it's just placebo. The other thing I think is knowing your other risk factors, because there's more risk factors for breast cancer than just family history. And there's ones we can prevent. And there's modifiable and non-modifiable. We can't prevent being a woman and getting older. You can't prevent your family history, right? You can't prevent if you had radiation as a kid or what age you got your first period. But if there's some preventable risk factors, talk to your doctor about that and say, okay, so what can I do on the prevention side? And that doctor should be able to give you 2-3 things that you can work on personally to reduce your risk or to help to modify your risk. Because cancer happens, whether you're vegan, whether you exercise, you don't, if you smoke, you don't, whatever it is, cancer happens, but we can take as much charge as we can and try to work on wellness as a mindset and a lifestyle too.
Yeah,
early detection saves lives. Early detection saves lives.
I was riding my bike 20 miles a day. I thought I was healthy. Had nothing to do with breast cancer.
Right? Well, you were in the best shape of your life to fight what you went through.
Yes, you were.
Right. Thank you, God. Right. God did that. But the other thing too is that only 5% of breast cancer is hereditary. Right. So when just because your mom didn't have it means nothing.
Yeah. Doesn't mean that you can't get it.
That's you can't get it. So know that. You guys are awesome.
Real quick, pros, cons, thumbs up, thumbs down on thermography. We got a question in the chat and we cannot let this go. What we need to talk about,
I don't even know what that is. What is it?
So thermograms, look at the heat signature. They are a test that looks at the amount of metabolic activity and heat that something is giving off. So it's like when you go through the airport security. I read an article last year, a year before, somebody went through the airport security and it detected their breast cancer. And you can see on the picture, this big giant lump. Well, yeah, that's because their cancer was more advanced than it should have been.
And it's hot. Because it's growing.
It shouldn't be giving off that much heat. And so that's the thing with the thermograms, right? Dr. Williams, you get patients who ask you and when you give talks and things and and you see patients about thermograms.
Right.
Yeah. So what I say is I'm more research based. And so I have to kind of stay on top of the research with thermograms. I'm not against them. If a patient or a woman chooses to get one, I would be fine with that, but I would still kind of want some follow-up with that. I'm not encouraging all my patients to get thermograms right now. I'm strictly with the mammograms, but you have to be open, right? But we also have to follow the research. And when I'm telling patients things, I want to tell them based on what research has said, this works, this detects this, and I'm just not up to date on the thermograms for as far as clinical baseline studies.
Yeah. I put a link in the comments. FDA does not recommend thermography for cancer screening, for breast cancer particularly. But I do have naturopathic doctors in my community that I partner with because patients won't get mammograms. They don't want the radiation. They have holistic practitioners. And the nice thing is that we partner together though, because if that person has a strong family history or if they get their thermogram and they feel a lump and there's something going on, their doctor will then say, well, you know what? Why don't you go see my buddy, Dr. Gary? She's not going to try to do a surgery on you unless you need it, but let's partner together. And so I love that you said that, Dr. Felicia, because it's so true. It's not that anyone wants to discourage whatever your practice is, but we do want to give you the best, right? The highest sensitivity, the greatest early detection. Because like Dr. Mary said, this is saving lives, right? Early detection.
That's all we got. It's all we got.
Saves
So
lives.
my friend Michelle Christian, one of my good friends from Atlanta, says due to history and genetics, is having mammo and MRI every 6 months too dangerous. Is that much radiation bad for you? I still say not as bad as cancer. Right.
No.
MRIs are magnetic, but the gadolinium, I think there's still some data that's showing that long-term effects of that much gadolinium can be can have questionable effects. But the MRIs are going to give you magnetic waves, so they don't give you that same degree of radiation as the mammogram.
Mhm.
You're okay, Michelle. Whoa. Thank you so much, you guys. Will you come back?
Oh, sure, anytime.
I like
Of
this,
course.
these doctors, these nurses that are doctor things, Mo. They're
They're
pretty
breaking
nice.
it down.
I know. Thank you for
Mhm.
everything. You guys rock. So
Our pleasure.
Thank
yeah,
you.
we'll have to come back and talk more about every, because we have so many things. I mean, there, when I called you, we had a list of things we could talk about. So we'll figure out, you know.
Next month. Next month is Breast Cancer Awareness Month, and
Yeah,
the-
so
we all got to pull out our PowerPoints, and we've got so many talks to do. And so we definitely want to have you back. We want all the information. Are there websites where people can either follow you or can look you up or can get in contact if they would like to chat with you more or invite you as a speaker or anything like that? Is there someplace we should look for you?
I will put my website in the chat.
you hear, we'll put it in the Facebook chat. Okay, we'll copy it
Okay.
into the Facebook
Yep.
chat.
And if you have a social media presence, we would love to follow you as well.
Yeah, and
Absolutely.
you know, I met Dr. Mary because we called the Oncology Nurses Society. So we're gonna try to partner with you guys on more things and work with you because we need you. And
Absolutely.
you know, need you know, everything that you're doing for us. So how about you, Dr. Felicia? We'll put yours. You did.
Yes, I put my email into the
Got
chat.
it. All right.
My God, Emory is everywhere. Y'all are just doing it. I love it. I love it so much. Wow. Well, we hope this has been relatable and reliable and real. That's what we set out to do every single Wednesday night. We want to do a platform where people can ask their questions in real time and get answers. And the information is sound and it's something you can take back to your family members and have these conversations because we know it's not easy. When one Black woman to another, we know what it is, but it's going to save some lives. And so, you know, thank you guys for watching and joining us. And the doctors are in. I love it.
Doctors are in. The doctors are in. The doctors
The
are
doctor
in.
nurses are here for you.
Doctor
The
nurses are here.
Oncology, oncology nurses. Okay.
You're hearing it
I know,
straight from the
oncology
source.
nurses. Oncology. So
Mhm.
I'm also going to put in the chat our Magic Touch celebration, September 19th. If you're in DC, we're going to have an awesome party. We're going to have dancing. You know, we're going to have dance. And we're having a breastie parade. Breasties can come for free. We're going to be COVID safe. You have to have a vaccine to come to our party.
Good.
And you have to, you know, prove you're vaccinated, and we're going to wear masks. We have Magic Touch masks, and we have magicians. We have food trucks. It's going to be an awesome party. I'll put the link in the chat. Come to our parties, and breasties are free. Kids are free. Come dance with us and celebrate our first year. So thank you
Awesome.
guys.
Congratulations on your first year.
Thank you.
Thank you so
And we'll
much.
see you next week. Breasty love.
Take care.
Thank you so much.
Breasty love.
Breasty love.
Bye, everybody.
Thank
Bye-bye.
you
Bye-bye.
so much. You guys are awesome.